reiterate what Dawn has said, and I agree completely that in a sense there's no, as you will see in my talk, there's no strict guideline on what you should do and should not do, but there is a baseline screen, so there's something that you can fall back on. And then you work back from this baseline, you decide whether you want to proceed or you don't, or even don't even go there, okay? And this is very important because, again, I agree with her completely and entirely that the last point, you must exclude infective causes first. Because you know what do we have for treatment? We have two things to treat. It's all the steroids and all the antibiotics, the antivirals, right? There's only two arms that we can treat on. And once you've decided which arm you're going to go, and sometimes you have to go both ways because you're not sure, so you have to cover and then treat. And some of the infections, you need the inflammation as well, so it goes hand in hand. But you need to know if there's underlying infection that you need to control first before you can start the inflammation. So that's something that is very crucial to keep in mind, okay? And so one of my principles for investigations, I agree completely with what she said. In a sense, it's fishing, but I don't like the word fishing because it means that we don't know what we're doing. We know exactly what we're doing, and this is the thing. See, the first thing is, I do the investigation because I don't know what's going on, right? So you want to do something to guide you. Is this inflammatory or is this infective? And I always tell the patients, that's what my baseline is, because then I'll know which end you are at, all right? And then if I can't already tell. So sometimes you look at it and you know straight away from instinct, from experience, this is the HLA, I'm not going to work you up. Or there's other clinical signs that put the evidence towards more inflammatory, and then you are like, I'm confident, I don't need to do the investigations. Then don't do the investigation. It's not an obligation that you must, okay? I do investigations, or you asked just now your question, like when you have a patient like that, what do? You need to decide whether the disease is active or not, all right? Is there inflammations? Is there active inflammation? All right, so again, clinical signs, is there pain? Is this acute? It's like, I have no symptoms, I'm just like, can't see, you know what I mean, kind of. So you need to know if the disease is active or not, and that's when you need to decide early on how aggressive you want to be, because as in with any immune-mediated reaction, you need to hit hard, fast, and early so that you can get it under control. Otherwise, the disease lingers on and becomes chronic. Even an acute HLA B27A, can become chronic if you don't manage it well. All right. So that's why we hit very hard for the acute AAUs, and then they get better, and then they tend not to respond. But then you will have those few cases that weren't managed well, and they will always have subclinical inflammation, patients not compliant. Sometimes it's not the doctor, sometimes it's the patients, they not I feel well stocked medicines and everything, and they always come back a short period of time with a few cells there again. Yeah, so they become chronic, right? So don't always get fixated, oh, this is acute AAU, it can't be chronic. And some of the investigations you do is not only for diagnosis, it's for follow-up, for the systemic treatment, for fitness for systemic treatment. You want to know if you can give immunosuppression, and you want to know what kind of immunosuppression you want to give, okay? And I like to say this, in a sense, is in uveitis, some patients, like sometimes you come up like with the diagnosis, the textbook gives you 100 diagnoses, and during exams you always name all the weird diagnoses that you see, but remember, common things first. So please exclude common entities, and you need to know your regional-based commonplace entities. Most of our textbooks are based in the Western population, and the disease is slightly different. So in Asia, you know there's something very different. TB is like topmost on the list, all right? And we have less of sarcoid, but we do have sarcoid. But TB is something that you want to rule out before you start talking about sarcoid. It's just how endemic it is. And then that leads to another question. Because TB is so endemic, you will have a lot of patients, if you do your MAN2, that are positive, and are they then TB? That always is our eternal question, right? So you need to know. I like to say that if the patient first presents to you and they're responsive to therapy, then stop. Don't go on, don't think too much about it. The patient's getting better, not losing vision, don't do anything. Be happy that you've achieved what you need to achieve. But if the patient is non-responsive, if there is something funny about the presentation that is not quite typical, or if it's progressive, or if it's just happening too much, too often, like every few months they come back, then something is not right. Then you need to stop and reevaluate, look back at what you've done. Sometimes, for us uveitis doctors, you get the cases referred to you and some things are done, so you don't get a good feel of the patient. Relook at all the investigations, redo some if you need to, because some labs have differing results. And then you just have to just stop and rethink, are you on the right track? So that is very important. So a lot of times I get asked, when do you do investigations? In my institution, we tend to do it for everybody, but in the textbooks, we always say very young, very old, very bad uveitis, bilateral, granulomatous, if it's posterior, and of course if it's scleritis. But what's the point of investigation? Okay, we put these criteria because the investigations are meant to guide the treatment. So if it's very bad inflammation, the reason why we investigate is because we know it probably needs to do something more. Probably they need something else, or it may be associated with a bad disease or a bad infection. That's why they present so fast and so aggressively. So that's why we investigate those bad cases. And in the young, we want to make sure they don't have systemic disease associated. And the very old, you also want to make sure you're not missing something else that could be affecting them systemically. All right, so this is why we investigate. So don't ask me, when do you work out? I work out when I'm worried about the patient. All right, when I'm worried that I can't manage without the knowledge of investigations. So there's no hard and fast answer to that. And then the other thing is practicality, there's cost issues. And I can't emphasize again what Dawn said, history taking and clinical chart review. Sometimes it just means going beyond your own discipline and looking, make sure they don't have medical issues, because sometimes they don't tell you. And again, as we said, we don't want to fish, bring out a big net and catch a lot of things, and then you don't know what to do with it. So you can't interpret it, okay? So some tests will be helpful, some tests will be misleading. Don't do a MANTU if you don't think it's a chronic AAU and it's going to be TB, because I tell you in Asia, 80% of the time you get positive MANTU, then what are you going to do? You're going to tell the patient, oh, you need to go for anti-TB, you have TB AAU. In fact, then you will find that in Asia, all our AAUs will be TB AAUs and not HLA-B27 AAUs. So that is something that you need to be mindful of, okay? I'm not saying that we don't have TB AAUs, we do, but you need to distinguish them very carefully, because if you send everybody to get TB treatment, you'll find there will be a lot of defaulters and therefore increase your resistance strains in your country, or you'll find that your ID physician will start calling you and say, hello, what's going on, okay? So again, the history taking, we've gone through that, but sometimes it's good to go targeted, because your patients don't come in thinking that you want to ask them about the bowel symptoms and your joints and rashes. They're like, just look at my eye. My eye is the problem. I'm not interested in my rashes somewhere else. But specifically tell them, this is important. This is one area. I need to look at the rest of your body before I can tell you what's wrong with the eye. Sometimes they won't tell you and they forget, and you can ask them again. So these are my poor residents. They will say, I've gotten a good clinical history. I've asked. And the patient comes in and says, oh, by the way, I have this rash here. The resident looks at me like, but I asked. So sometimes they forget, so repeatedly ask them. Chase those things that you think that looks like it, all right? And be specific, because they don't understand sometimes. They just want you to look at the eye, okay? And then always ask family history, like exposure to TB. Then you'll know how worried you should be about that positive MANTU test, okay? And sometimes just ask, do you have history of joint problems? And they can tell you, yes, I do. Of course, sometimes it's misleading, because as an older individual, you always have joint problems here and there. So you need to make a distinguishing factor, whether they've had it chronically, that they actually need to take medication to relieve it. Okay, then you know how severe it is. And again, as Dawn said, when my residents call me and tell me, okay, I have a uveitis, the first thing I ask is, what are the KPs? I don't care about anything else. What are the KPs? Is it fine? Is it granulomatous? So this is really what you need to know. Granulomatous, non-granulomatous. Because that will guide you. Because once it's granulomatous, you know what you're going to think of already. And you need to know that you're going to have to exclude certain things, all right? And this is just one sign that you need to worry about. Of course, the rest will help you guide you along the way. But just remember these pictures, and Dawn has shown you a lot already. And remember to look at the patient. Don't, for us, we're eye doctors. We tend to, okay, sit down, just see the eyes. And sometimes we don't even look beyond the eyelids and face. So remember to see the rashes. If they come in with a rash, they may not tell you. This may be something that they've had, and you see them for the first time, you're not sure, but notice the rashes, look at the hands. When they come in, look at the posture. It's actually very important when the patient walks in. Are they on a wheelchair? Can they walk? Are they limping? Are they walking straight? Are they like crouched over? Can they even put their head on the slab? Are they struggling to put their head on the slab? Because that already tells you maybe they've got neck stiffness. Look at their fingers carefully. Sometimes they've got rashes. And really, sometimes if a patient in a hot country comes to you all bundled up and like sleeves, make sure you have a look, because sometimes they're hiding a rash that's bad, all right? And ears are something so easy to see, but with hair blocking, you won't be able to see that. So important to look out for those things. So the ideal wish list, you can see in all the textbooks, can be everything and anything under the sun. So blood tests, imaging, general imaging, ocular-specific imaging. All right. So I always say again, find the cause of disease. You may want to do these. For treatment, you may want to do these. Okay. You want to make sure they're fit for your baseline corticosteroids, if not hepatitis B, and baseline like corticosteroids, but not even immunosuppression. Okay. And of course, don't forget your imaging. Now we've got very fancy stuff like OCTA, OCT, ultrasound, B scan is very important. It's a very simple test that most people will have. As long as you do cataract surgery, you have an A scan, then you probably have a B scan. So every clinic should have that, and that will be very useful for you not to miss important things. All right, you don't need the OCTA to do things. You can have an OCT, which is useful nowadays because it's a surrogate to repeatedly doing your FA and ICG, and it's non-invasive. So the OCT is a very useful test. And of course, your general imaging. And why I put this, and of course, don't forget, don't be afraid to do aqueous and vitreous taps. We have now a lot of experience with aqueous and vitreous taps. We know it's relatively safe to do them at the bedside. Okay, why I wanted to put this up is because look at the cost. This is in Singapore dollars, unfortunately, and this is already for our subsidized patients. That means these already have government subsidy. So you can probably times 2 for foreigners. So this is how much it would cost you, you know? So again, I just want to show you that, and then again, as what is important for investigation, as John has said, you need to find where is the source, the main area that is being inflamed. Is it the back of the eye? Is it the front? Is it the intermediate area? Where is the main source of the inflammation? Okay, so that's important for us. Then you can start narrowing down. So like just say screening for anterior uveitis. Just that, again, you need to know whether it's acute and chronic, and that's chronicity. Not only duration, but just physically examining and looking. If they're like posterior synechial, you know this has been going on for a while, and there's lingering inflammation. You can make a decision whether it's that, and then you start thinking, is this granulomatous, not granulomatous? So really you can think, you know, which way to go. And then these are the acute causes, more of the chronic causes. It can't mean that these acute can't become chronic, but if they're acute presentation, then you want to focus on all these. And then of course you have that baseline, and I put that cost up, just now all the numbers, adds up to something like this in local, and this is subsidized, so if you want to be a private patient or in the private sector, it might be a lot more. And this is just for this baseline. If you want to do additional, including HLA, it's another almost $1,000, almost twice. So do it only if it's warranted, because it's a lot of, it's extra money, okay? So baseline, why I like to do these baseline, so what I hear is just to say that, you know what, if a patient comes to me and they've been referred with some anterior uveitis and they've already been started on steroids and they're getting better, I may not even investigate because they're already responding. What am I doing that is in excess to what I can offer to the patient? Except if the patient isn't. So now in this stage, there's two things. One is patient wants it. You're obliged to disclose that you can do the investigation and sort of maybe find out if there's anything wrong with them, have a trick. Because some patients ask, why will I have this? What is the thing? So you can say, I can do some investigations, you know, and then we can react on that. If you want to know, maybe just look at your general health screen. You know, I like to do FBC and ESR, CRP because if it's mostly normal, I'm not missing out something. General health, like FBC, I can always say, oh, you don't have anemia, and then they're quite happy with that. ESR, CRP lets me know that this is not a systemic disease I'm missing. Occasionally you do it, you get an ESR and CRP that's much elevated beyond the inflammation that you're seeing in the eye. Like if you see a mild or moderate uveitis and then you see an ESR 60, 80, then you start wondering, do you have something else going on with your body? Is that why you're flaring up? And then you can, you know, look carefully more into them. I like these as baseline, and sometimes ESR is elevated. I know that the inflammation is quite bad, that is so much that spilled over from the eye, and I can detect it in the system. So I think that these patients, I may want to follow a little bit more closely because they may not necessarily always have increased risk of recurrence. Syphilis is just something easy to do, and I always tell them, these are chronic infections that can look like anything, and they're easily treatable. So if you have it, and this is the cause of your inflammation, we can treat you, and it's generic, it's nothing fancy, and it can look like anything, that's why we just do it. Urine FME I like, because nowadays if I do it, I can detect protein, I can detect sugar, and sometimes we don't get taught very often. Undiagnosed diabetes the first time can trigger sort of anterior uveitis, and sometimes you get nothing, and then all you see is, hey, you know what, the sugar is very high in the urine, and then we find, oh, this is a diagnosed diabetic. So not just as a uveitis doctor, but you're also doing your job as a medical doctor, that you've detected something wrong with the patient when they come. So This is a very useful test. And then you can look at the white blood cells and look for infective causes, crystals. Not so common cause, but increasingly being published is things like nephritis-related uveitis, especially in kids, called TINU, tubular interstitial nephritis with uveitis. So it's actually a very good screening, because if you look at protein, you start seeing a lot of protein, you wonder, why is this person having proteinuria? You know, and then you can do a renal panel, and then you can start thinking, could they have something else wrong with them? So this is cheap and simple, easy to do, tells you a lot of things. I like this test. So MANTU, if you think it's chronic, and chest x-ray, these go hand in hand, because at least if the MANTU is positive and the chest x-ray is clear, I think, oh, just have latent TB, it's endemic, it's fine. So this is just goes hand in hand. I put it at the last because they're less useful, but sometimes you still need to get it done, because at the end of the day, if the inflammation is not getting better, you want to start steroids, you just need to get this out of the way. So I do it as a baseline first sometimes. Okay? But again, this is just to say that if there's no progression, everything is fine. Actually, the patient's already responding to therapy. When they come to see me, I don't even bother doing the workup. Okay? I only do it when they relapse the second time. I say, okay, second time, let's find out what's going on. If they get worse, they're not responding, right? Or they progress to posterior disease, then I do more. Then if your AU is very severe, and then you already know at day one, hourly topical is not going to just cut it, it's something else is going to, you're going to need something else, or if it's getting worse and worse, or if it's very chronic and recurrent, then you may want to do more, okay? You may want to do more specific immune screens. I like to do ANA and rheumatoid factor, not because I'm going to refer them on, but I like to know that if there is an immune basis for this inflammation. I always tell the patients that if you are systemically well, the rheumatologist is probably not going to do anything else. If the ESR and CRP are not sky high and they're just a positive or vague ANA and rheumatoid factor, I don't necessarily have to refer them, but I do tell them, look, you have that immune imbalance in your body, and that justifies, I know that you're more on the immune track. Sometimes I don't, ANA and a rheumatoid factor are cheaper than HLA-B27, which costs like 200 over in Singapore. These are just like $50, you know. So I like to do them because I know that they have got immune basis going on, not because I think they're going to get rheumatoid arthritis. I do warn them that you may, when you get older or whatever, or if you develop symptoms, go see a doctor. But for now, everything seems to be okay. So I just like it for the understanding of the immune system. And then of course, if you want to be really specific, you go on to this. So again, so there's screening. Just now I told you this is screening. You don't know really what's going on, but you just want to have a feel of the immune system, whether they're healthy or not, if there's anything going on in the body. Then there's science-guided things that you want to rule out. If there's a hypertensive uveitis, you want to make sure that it's not a viral. Then sometimes I just tell them, I only want to do one test, and that's the AC test, because I just need to know if you're viral. If you're not viral, I can give you steroids for the inflammation, and then treat you accordingly, or I don't even need to give you steroids, I can just treat your viral infection, and that's it. Okay, so the AC test is something that I would consider if there's a high IOP. All right? If there's a hypopin, of course, again, do you want to rule out infection, you do an AC test, and do you want to be more specific by doing some of the other cultures and everything? If there's syndicate, again, as John had mentioned, you want to rule out TB, sarcoid, syphilis can cause anything, so it's something easy, and I would like to get it out of the way. And then, of course, you can do all the other relevant. These are not very specific tests, but they're useful. And again, look at the PAS as intended. Then again, if you see iris, look for nodules, look for mass defect, look for atrophy. All right, again, you want to rule out viral. If it's associated with granulomatous inflammation, again, you want to be targeted. So you can limit your investigations. So, and of course, you want to look for iris atrophy, you want to look for nodules, because that will tell you whether it's granulomatous or if it's going to be viral. And now, increasingly, we're getting more and more evidence that other viruses affect the eye, but our labs are limited to a very few. CMV, HSV, VZV. If you're lucky, I think NUH has EBV as well. But again, EBV is not real, no real treatment. It's again a mixture between acyclovir, Velg, and acyclovir. So, is there? So sometimes I ask, if you know what it is, but you can't treat, is it worth knowing? So what do you do in these cases? You treat the symptoms, and you avoid long-term steroids because that makes virus worse. So people ask me, oh, do you not? Well, first, if there's inflammation, I will give a bit of steroids, but I wouldn't put it very long and very high dose for very long if I think there's an underlying infection that I can't really control. So there's no hard and fast rule on how you treat. Again, for scleritis, it's a little bit like AAU, but you know scleritis is more associated with autoimmune conditions. And then do you want to do autoimmune screen earlier on? Again, I like to, if they're very mild, I tend to just do a baseline uveitis because I like to look at the ESR and CRP. Yes, I can get caught out, but if the patient's not responding, then I go on. You see, so a lot of people ask me, but don't you get caught out? I said, as long as you follow up the patient and then you know they're not responding, then you know you need to do more. But if they're responding, then you can stop there, all right? So that's the point. It's never, you see, uveitis patients are never see one, diagnose and treat, and immediately 1 week later, they get well. I know when we present, we make it look very easy, like, oh, this is granulomatous inflammation, oh, and I did this test, and you see the diagnosis like this, and I treat this, wow, see, recover 6/12 vision, very nice. But you know how long it takes us to achieve that? We never really tell you, right? I mean, 1 week, do the investigations, next week we see the investigations, okay, can we start, okay, we try, another week. So it can be months before we achieve it. So don't be put off by our presentations when we give you a case and it looks very well, and when we present it, it seems like we know exactly what we're doing, and timeline looks really nice and short. You know, in clinical life, it's not like that. And our point here for this is to demystify uveitis and make it fun, okay? Because it's like a detective game, you know. You see a sign, you chase it, you find it, and you get a result, and it answers your question. You feel good about it, and then the patients feel well, and they like you, and they think this doctor has done something good for me and has told me something I don't already know. All right. So again, targeted versus just screening tests. Okay. So for granulomatous uveitis, you want to really rule out, in our local setting, TB. Okay. And how aggressive you want to rule out TB? Mantoux test is still the gold standard. All right. But we have the eyeglass. So consider them if you really have a high index of suspicion, all right? And then and a high index of suspicion means you're getting a choroidal disease or posterior uveitis with vasculitis, typical signs that you get with a TB uveitis. Then you may want to do the eyeglass earlier on. And people ask me, do you do both, one or the other? Then I answer them, how suspicious am I, and whether I'm going to make them take the TB medicine, all right? Because sometimes I just want to make sure it's negative, because there are instances where one is borderline and one is negative, or one is positive, one is negative. So if I think this guy needs immunosuppression, whatever it is, I just need to rule out TB, and I'm going to give high-dose immunosuppression for a long time, I want to get both, because I don't want to cause issues by reactivating the TB. I'll do both. Or I think this could be really a TB, and I really want him to take the medicine. I do both, because if they both come out negative, I'm safe. I can give as much as steroid as long. I don't have to worry about latent TB. Latent TB is an issue here, and we've had patients who didn't want the TB medicines, had the high-dose steroid, and developed extrapulmonary TB elsewhere, like lymph nodes or other things. So it is still important to be mindful. It's not very common in my practice, it's not very common to get the systemic biliary TB because of reactivation, but you can get these other conditions. So just be mindful of that. So again, when you ask me, should I do both or what? It's how I feel the case requires it. If I think I want to know for sure and I want peace of mind, I don't want to cause problems, I'll do it. Or I really want the patient to go for treatment, I want to make sure both are positive, then I have really good evidence to tell my ID physician, this is TB-related uveitis, please treat with the full works. All right, so that's what dictates your investigation. So when we do investigation, we're not really fishing. We really want to know we're really asking a specific question, and we want the answer based on that. All right, so again, the autoimmune screening test, rheumatoid factor is more useful because you want in the young, less than 10 years old, you might want to do this because you don't want to miss a juvenile rheumatoid arthritis, which is one of the most common causes for AAUs. Again, the most common the immune one is HLA-B27 adults, but again, I don't necessarily do this because you don't really need that to know that's HLA-B27. Sometimes I tell the patients, if you want, I can do this. If you're covered by insurance or you really want to know, I can do this, but if you're not bothered, we can just hold off because this is money. It costs about $200, so it's a little bit expensive. Yes, on CRP are very good, and chest X-ray for sarcoid. Specifically, and you have to tell the radiologist to look for sarcoid, otherwise you get a routine generic report that says HiLA is empty, heart size is normal, no active lung lesions, and that's very frustrating. So I always send them back and say, please comment on the HiLA space. Is there or is there no HILA, and should I proceed to a CT? If you give them specific instructions like that, then they can say, oh, no evidence, and then no need to progress, or if they're not sure, then they say, oh, order a CT. Then at least I can tell the patients, look, we need to do additional tests, because sometimes they say chest X-ray is normal, why do you want me to do a CT? You know, so it helps when you speak to the radiologist. Again, some of these are again helpful for infectious. Some people like to do procalcitonin. The ID people like to do this, but I found that most times it's negative. So, but it's something that you may encounter. I find that the most useful for uveitis, doctor, is actually an aqueous and vitreous tap. Okay, that tells you the most information immediately, because you're going really to the source of the information. Okay, so that was just for anterior uveitis and scleritis. Okay, what happens if you get posterior uveitis? What do? Most times the residents start panicking there. They just freeze. They see this and they're like, oh, what do I do? And well, you take a deep breath and then you think, is this vitritis? Is it in the anterior or posterior? As you mentioned, is it spillover anterior uveitis? So do you see a lot more cells in the front than just a little bit cells behind? Then you think, the source probably is the front, and then there's a spillover. But if you see a lot of cells behind, and then a little bit of anterior uveitis, then you know it's not spillover, it's posterior uveitis. The intermediate is the gray zone where you don't see a lot in front, you don't see a lot behind, but you just see some in the mid-vitreous. Okay, so and then you may, if you look peripherally, you see some. I think I see sheathing in the periphery, kind of thing. That then you can classify as intermediate uveitis. And this is a very simple way. Once you see vitritis, you want to start looking. Is there retinitis, choroiditis, and vasculitis? Right, that's the next step. And of course, you have just now Dawn showed you all that. So now we classify into all these. What can it be that can lead to all these things, right? Because you have, once you see this, you have this in your mind. It could be this and that. I want to exclude number one infection. Could it be this? Could it be that? Okay, and then again, I like to fall back. Your baseline, right? You want to know. I want to know if there's total white high. Is it infection? If the ESR and CRP are elevated, I'm going to be a little bit more worried that this is a more aggressive disease. Posterior uveitis, I like to do the MANTU. If not, I might straight away go in to do all the eyebrows as well, because if I see vasculitis in a certain way, and it's more vein, I would start thinking, could this be TB related? Chest X-ray therefore comes in useful. And of course, if you see in the back posterior choroidal small punctate, then you think, could this be sarcoid? Then again, the chest X-ray is useful. And because sarcoid go hand with TB, you need to exclude TB before you can call sarcoid. So you have to rule out the TB. So in those cases, I like to just do the two eyebrows, get it out of the way. See, either is or isn't. And then VDRL and all the rest I mentioned. Okay, and I mentioned to you again, how aggressive you work up is how bad the uveitis is. If it's just a little bit, vision 6.6, I'm not going to be very aggressive. And I monitor if they get worse. All right, no complication, nothing, very little. Yeah, I might not do so much. But if it's getting worse, counting fingers vision, a lot of vitritis, I can't see anything, vasculitis, retinitis, I'm going to be aggressive because I know this patient, if I don't do something fast, he's going to go blind. All right, so this guides how aggressive you work it out. So again, targeted tests, right? You have your screen, and then you go, do I need to rule out TB? Do I need syphilis? Was VDRL enough? So I've had residents come up to me and say, you know the AAO guidelines says you need to do all this tests, otherwise you miss the VDRL. So I said, unless I'm suspicious and there are signs and evidence suggestive, or I'm going to give very high dose immunosuppression and I want to get VDRL out of the way, then I'll progress to doing the more specific VDRL related tests. Otherwise, I'll just stop with the VDRL screen. Okay? So this is how I do when I would be more specific. Sometimes it is very bad inflammation, I will just do HIV because you're going to get something strong anyways, and you don't want to be caught up with infection because HIV is quite common. So I had this patient once come in with intermediate uveitis with some vasculitis, and he was a youngish man. And then he said, I have no money to do investigation. So I was thinking, youngish man, okay, fine. So this is the most baseline, cheap, everything looked fine. VDRL was, we didn't do VDRL at that time because it's not covered by the, A&E walk-in kind of thing. But so I looked at him, okay, maybe intermediate. Should I, just cut corners and give him something? And then I decided to look at the charts more carefully. So I'm reviewing the patients and my fellow is telling me all this, and I'm not really looking at the clinical charts myself. Then I decided to look at the clinical charts myself. And then on the headline, usually if you get a clinical chart, at least in Singapore, they will tell you this patient has some flag. They will flag that if this patient has some other medical problems, and as usual, it's halfway hidden by something, but it is HIV there. So you can get caught up with HIV. They can look like anybody. So and then I said, oh no, sorry, you have this. I'm going to do the full work, so you're not going to cut corners. And is also sometimes as doctors, you try clinical experience. You think maybe I can cut a few tests, but sometimes you just can't, and you don't have to feel bad about it. Sometimes you just need to do the full workup. And then he turned out, of course, BDRL positive, LLA, HIV positive, and florid uveitis. And all you need to do is admit him for IV, and then he cleared up beautifully and recovered vision from counting fingers to like 6'9", 6'12". And it's just, and when we asked him specifically, do you have any medical problems? He looked me straight in the eye and said, no. So again, sometimes they are not, they're a bit ashamed of the diagnosis. So look at the medical charts yourself and don't rely on residents. And always, sometimes, even if you haven't caught the patient, talk to the patient yourself, because you can really get a lot of the information by seeing the patients. Sometimes you have a busy clinic, you can't see all the time, but it does make a big difference. Okay, and again, specialized tests. So again, if you are endemic for some of these things, you can do it. Always be mindful that there are things like that, and genetics, and you can go on, right? So I mentioned this. Again, how do you work out vasculitis, posterior uveitis? I always like to differentiate whether it's arteritis or phlebitis. FFA is the number one key thing to do, if you can see, of course. If you can't, you just try it. Sometimes you can be surprised what you can see. And then if you have the FFA, you have vasculitis, you want to make sure there's subclinical choroiditis, because that tells you something, right? Choroiditis, you start thinking TB, granulomatous, BKH, sarcoid, SO, and everything. But again, the clinical history will tell you. So sometimes you work back and forth. You see the clinical history, you already have an idea. Some uveitis are very classical. BKH is classical. So you see it, and then you know what you need to do. Specific targeted investigations so that you can meet the criteria of BKH and then manage the patient, right? So again, don't hesitate to do AC tab and vitreous tab. Again, I won't go through this, but again, what I wanted to emphasize with the vitreous tab, there's a lot of things you can do. Cytology is actually quite nice to do. Of course, you can do all the PCR and IGH rearrangement, but this is important to do for your masquerades. So anytime your patient gets something, is not recovering, not doing well, not doing as you expect, then you have to reconsider, do I need to do more? Do I need to do something more invasive, like a vitreous tab? Should I do even although not very common in Asia, should I do an MRI just to make sure there's no multiple sclerosis? If they're not recovering, I think it's warranted. But first time intermediate uveitis, you want to go straight away from like MRI, maybe not so necessary. So again, don't forget simple tests like these scans. I like to do them as baseline. Although you can see the choroidal, lesion, but this is important because it helps you for monitoring. Because you can see it smaller and smaller. Sometimes you see it here, you may not be able to tell. You can measure the depth, and the B-scan is good for monitoring. Again, serious detachment sometimes is useful just to look for choroidal thickening. We tend to forget this for BKH, and a lot of people want to just go on to OCT, which again is important. Sometimes FFA is all you need because they can show you the systolic macular edema and tell you about the vessels. So it gives you a lot more information. You don't need to go on to do an OCT, but you can because OCT is useful for follow-up of the height of the macular edema when you don't want to do an FFA all the time. And again, nowadays OCT is quite good because like for BKH, for monitoring. So BKH, you know, is a choroidal disease and the choroidal inflammation that irritates the retina and therefore gives rise to this serous detachment. And then if you treat with the hydrosteroid, it will get, the choroid will get thinner. So this is nice to monitor for the patients because if you start seeing the choroid getting thicker, they might get recurrence. This is for subclinical inflammation, and some of us still routinely treat subclinical inflammation. So as you go on to uveitis, you know that there are many ways to skin a cat, as you can say. And what you want to do is achieve good clinical goals. That means the patient does not have active inflammation, the patient can see, and the patient is happy with that. All right. So sometimes we do want to, so some groups of uveitis doctors do prefer to treat subclinical disease. Some of them don't. Again, you need to see within your practice and in your country what is the ideal thing to do. Sometimes it's just not practical to treat the subclinical disease in certain places because the patient can't keep on coming back. So you need to work out a balance of all this. There's no real right or wrong answer as long as the patient can see and is not losing vision and there's no active inflammation. So some people get very angry and fixated. Why are some people not doing this and why are some people not doing that? For me, I think it's very clear. We need to put the patient at the top of the list. Are they suffering? Are they losing vision? Is there active disease? Are you missing? Are you not doing your job as a doctor? If you have helped them regain the vision and there's no active inflammation and there's no consequence to it, then I think that's fine. But if they have lingering, of course, they're not well, they always get relapses, you've not done your job, then you need to see them. So find that balance within your practice and then you'll be fine. Again, FFA is useful for seeing leakages and looking at the nerve, looking whether there's leakage of the nerve. Choroidal disease or BKH is something that we want to do. So you'll see investigations, some go with the disease. You know if you have this disease, you want to do all these investigations. Sometimes you don't know what the disease is and you need to do the investigations. All right, just some pretty pictures for you to see. So I just like to tell you this because I have a vested interest in ocular lymphoma. And as a pathologist, because sometimes it's hard to diagnose and people always ask, how do we diagnose this? And it's actually increasing in incidence. So, and always people say, oh, we have to rush it to the pathologist, and the pathologist, oh, there's no cells. So we've tried to use the fixative, and I use the pap smear fixatives because most pathology labs now will have liquid pap smear fixatives. It's either called thin prep or sure pap, and you can get it in a bottle like this, and then you can do your vitreous tap and you can put it in. I've had people send samples from Myanmar and Vietnam, and we can actually still make the diagnosis of a lymphoma, even if it's like shipped from overseas. Okay, so that's something useful. Just very quickly, I just want to show you some cases to show, and then like how you can investigate. So this is the Indonesian lady who has this kind of KPs, and this kind of KPs, if you look at it, with experience, you'll know that these are a little bit atypical, but they border on granulomatous if you look at them quickly. But the shape is a little bit funny. The way they look is a little bit funny if you look at a lot of granulomatous KPs. So you may start getting suspicious. Are these really keratic precipitates? Keratic precipitates are just accumulation of immune cells on the endothelium. All right, so are these really immune cells or could they be other cells? Okay, and then you get these, you see the vitritis is forming these large clumps, and it's quite hazy here. You don't have to be an advanced student to know that there's vitreous haze here. And if you use the sign classification, if you can't see it, it's quite advanced vitritis. Again, it's advanced vitritis. And of course, you would do the works that I said, or vitritis, is it TB, is it infected, all that kind of stuff. But if you look very carefully, look, there's not much vasculitis. That's quite unusual for a case with so much inflammation. It's so pristine, All right, and then if you do FFE, you'll find that there's no CMO, which is a little bit unusual with such florid inflammation. And so after you've excluded everything, most of us will try, let's try a course of steroids and everything, and then they don't respond. So what do you do next? So don't hesitate to go and do a vitreous biopsy, because you can always look at the cytology to exclude the masquerade, and this patient has lymphoma. So there's these lymphomatous cells that stain for CD20, which is a B cell marker, and on cytology they look very ugly. You don't need to be a pathologist to know that this is an ugly cell. All right, a big and ugly cell that can be nothing but cancer. All right. So, so in this kind of case where you see something like this, clinically I don't think it's a diagnostic. Do you need to really work it out? Because you can see there's a lot of vasculitis, the patchy sort of retinitis kind of things going on, there's vitritis. So always when you assess, make it mindful to look at the disc, the vessels, the vitreous opacity, and the retina. And retina means you try to discern if it's a retinitis or choroiditis. If you go through those, you'll never miss anything. So the disc looks fine, there's vasculitis, there's some retinitis. Why I say more retinitis than choroiditis is because they're more confluent. All right, choroiditis are usually granulomas or more round lesions. All right, the choroid also the way it is you'll see more round lesions. So this is not so round and it looks more superficial. Color is important if you follow Dr. Vishali. If it's yellow, we think infection. If it's white, it can be inflammatory, but these are soft signs. These are from experience, okay? It's not 100%, because none of these signs will read textbooks or follow textbooks. It's just based on experience. You hesitate, think if it's more yellow, you want to think of more abscess, that kind of thing. But this, is retinitis. So number one thing that you want to do in this case, anybody? What is the one investigation? Anybody want to? I always say this, also exam question, so what's one thing you want to do? So I always get asked, do I do an AC tab or a vitreous tab? Right? No question, this is your worry. Everybody will, if you don't know, you should be worried about a viral retinitis. And if you are thinking, you know that some viral retinitis are immunocompetent and some are immunocompromised. If it's immunocompetent, you may have a fluoride vitreous reaction. If it's immunocompromised, you tend not to have a vitreous reaction. This person has a little bit of vitreous reaction, right? But never 100%. But that gives you an idea, because you know, some, they don't get a lot of vitritis because they're immunocompromised. These are subtle things you need to think when you see the signs, because they tell you a lot. This picture tells you so much, you see. So anyways, one thing you want to do, so nowadays you have AC tab and vitreous tab. Nobody likes to do a vitreous tab. But in this case, you see the retinitis is quite florid, although it's not getting to the macula. But you know the patient may lose the vision fast, and you want to be aggressive in this case, right? Any form of retinitis. So I would prefer to do a vitreous tab and give some medication at the same time. That way, whilst waiting for the sometimes you already know this is going to be an ARN of some form. Which virus, I don't know for sure, and I'm not going to waste my time guessing because my tetraplex will tell me. But as I want, if I'm going to poke the eye for the tetraplex, might as well give some medicine, right? So you can give, and because it's so florid, you might want to give Foscanet, which covers both CMV and the herpes virus, so that at least you know that while waiting for admission for your IV, of course you can give the IV after that, you get maximum dose in the eye. So you see, sometimes the investigation is both therapeutic and diagnostic. And therefore I would push, in this case, rather just the AC tab to tell me, I can institute urgent treatment directly to the source of inflammation. So in this case, I would do a vitreous tab. So this is just to show you, there's many ways to do it. There's no right or wrong. You can do the AC tab and mid for the IVs, that's fine. But if this were my eye, I'd like to get more medicine in as fast as possible because you know, high chance of going blind, right? So the faster you go, the urgency is there. But there's no right or wrong answer. Sometimes you can't do it, it's not available. Do what is best for the patient at that point in time. So this was a VZV. And sometimes the patients don't tell you there's a fit and healthy lady, no medical history, then she comes in with bags of medicine. These are my Chinese medicine that I take. And then we're worried that they contain steroids because she's obviously has some form of immunosuppression. So I just want to show you this case. Again, you see this kind of hemorrhage, vasculitis, and with a bit, maybe there might be some retinitis somewhere. Is this a classical diagnosis? What is the investigation you want to do here? Of course, you can do your baseline screen, but you want to start worrying, right? Is this a retinitis? So this is to mislead you a little bit because nothing is 100%. This may look like a viral retinitis, like just now. So FFA shows you this is a 30-year-old Chinese man who complains of floaters and blurring of vision. What do you want to do? I think it's warranted for you to do everything, but sometimes it's just easy to ask the patient, do you have mouth ulcers? And you see this big mouth ulcer, and then, do you have genital ulcers? Yeah, I do. So this is not all cases will be classical, and not all of them will open their mouth and show you this, but sometimes if it's there, it's useful. Then you don't have to worry so much, okay? So this is a case of batches. But having said that, you're not going to do the immune screen, right? You'll still do it because you need to know for sure. But you do it with a guide that this is autoimmune and you're just making sure that he doesn't have anything underlying so you can give the immunosuppression. So you're very clear what you're doing for your investigations, right? Sometimes you don't know and you still worry. So if you didn't see this, you would still worry about infection, is this autoimmune, is this... You still have to exclude the infection first, right? And you'll still do those tests. So it's not wrong to do those tests, but sometimes just the history can help you narrow it down and know where you're going. Cystoritis, here, Don show you some nice. Also, make sure you just examine them. So sometimes they show you the ear swelling, quite classically. Then you don't have to spend a lot of time working out, and you know exactly what test to do. Otherwise, you have to do the whole screen. Sometimes it's very costly. Sometimes this just answers your question. And they do sometimes go hand in hand, because we've had patients that were seen by the ENT, and they go and tell you, oh, I can't see you because I've got a follow-up with ENT. So why are you seeing ENT? Oh, because my ear is like swollen. Then you know, sometimes it's not clear. So, and don't overlook simple tests like these scans. Sometimes you have a scleritis, you say, I've got, oh, you're so happy because scleritis, I see it, I made a diagnosis. But don't forget to look for complications, because there might be a posterior scleritis element. You just see the tip of the iceberg of the redness. So sometimes the posterior scleritis don't manifest with the very red eyes that you see. Sometimes it's very subtle, and the patients are really symptomatic. I really feel bad. But there's nothing there, you just blepharitis or you just a migraine. Please look carefully. Do a simple B scan. You see the teeth sign. In my experience, the patient's clinical symptoms is the most accurate. So listen carefully and do your due diligence to exclude the complaint. Yes, some patients are a little bit suggestive. If you ask them everything, they'll say, yes, I have everything. But those are the ones that you maybe take with a pinch of salt. The ones that are very adamant, no, I'm not better, I still have this. Take it seriously, because sometimes something is really going on and just exclude it. Sometimes you just need to have the peace of mind that you've tried everything. Sometimes you do find nothing. But I think those are important, and that helps with your patient relationship. And uveitis, it is extremely important to have that good relationship, because at the end of the day, sometimes you've done your best. They may not maintain full vision, but they understand. They know that you've sat down and spent some time with them. So just to summarize very quickly, just some things that I like to look at. If it's acute, I tend to think of more autoimmune and viral. If it's chronic, I tend to start thinking, is there an underlying granulomatous inflammation? If it's unilateral versus bilateral, when it's bilateral, I start thinking, could it be a systemic thing going on? Is it autoimmune? If it's unilateral, you tend to think, could it be an infection always? If it's granulomatous, you start thinking viral TB, sarcoid syphilis, right? And then viral, you start thinking, is there hypertensive uveitis? Because is there hypertensive uveitis, I really need to make sure it's not a virus. Because why? If you start giving steroids to a virus, you will trigger ARN. That's site-threatening, so that's a big no-no. And if it's, say, CMV, or CMV tends to not have the granulomatous inflammation, so granulomatous KP, so a bit tricky. But when we're talking about viral granulomatous, we're talking about the hepatic ones, the ones that cause the ARNs. So you don't want to just happily, oh, here's your steroid, and then next thing you know, they come back, I can't see, I've got massive ARN. Okay, and then non-granulomatous could be autoimmune. Having said that, non-granulomatous, at the back of your mind, nowadays we have the CMV anterior uveitis. Need to exclude that as well. But on the broad basis, if you take it as a whole, if there are smaller KPs and non-granulomatous, more likely to be autoimmune. Viral, you want to do AAC type. Infective, you want to do AAC type. There's nothing you can do about that. All right. Masquerade, again, AC, you can do a vitreous type. It's usually more useful. Scleritis, you may want to add to your routine screening, or if you have a targeted want to work up, do that. But always remember that scleritis is associated with systemic disease, so something you need to keep in mind. That is different from anterior uveitis. Okay? Posterior uveitis, you want to make sure they don't have systemic associations. These you can just ask. Have you been sick? Do you have diabetes? Have you had, were you in hospital? Have you had a fever? You're not well? Do you have ulcers? Joint pains? Everything like that. So you can ask them. Do you have history of HIV? Sometimes you just need to ask, or look at the medical history if you don't like to ask. So if you see, sometimes just quick screen into the medical records, make sure they've not had a lot of blood tests done recently, because if they had a lot of blood tests done, something might be wrong with their health. Vasculitis, when we see vasculitis, we try to classify, is it more arteritis, is it more phlebitis? If it's arteritis, you start thinking viral or systemic disease. If it's phlebitis, you start thinking of TB, sarcoid, maybe Behçet's. Some of them can be both, so you can't tell if it's very bad. But these are general guidelines. If it's a circumscribed lesion on the retina, it's a chororetinitis. If it's very ill-defined or diffuse, it's a retinitis. Color of the lesion I mentioned before. And then workup. Is it the screening versus additional? And then a more targeted therapy. And don't forget your ocular investigations are useful for you. And the blood tests or therapeutic monitoring. Okay. Always be mindful, even antiviral therapy, you should monitor. Some of the antibiotics, they're quite strong, you may need to monitor stuff. Immunosuppression, you need to monitor aggressively. Unfortunately, uveitis, when it comes to this area, you can kill the patient. unlike all the other ocular subspecialties where it's relatively safe. So you do have to be mindful of all this. So just to summarize that history clinical examination is key. You must think of cost and whether you can delay the diagnosis or therapy, and then when you order the test. So at least do a baseline if it's not getting better. Know how to interpret the test. Targeted investigations are always better. And then always remember that the patient is a whole and not just eye. And if you need to get help, and I do this, I aggressively warn for uveitis, if you need the help of the internist, go ahead and refer to them. Yeah, never mind if you do this with due diligence and make friends with them, they know that when you refer, you're worried, they will understand. Because sometimes we just can't have the capacity to monitor and follow up all these things. So I would refer, and I tell them very frankly, just help me exclude this. If it's clear, I won't bother you again. Or at least tell me what to do, and then I can do that. And if you're clear and you have a good relationship, they won't mind and they won't get angry and everything. And you learn something because you learn to pick up subtle signs as well. All right? So with that, I end my talk, and I hope that you have understood when and how to order some of the investigations.
Is it common for syphilis to present in the non-granulomatous way?
Syphilis is the great masquerader.
So
it can do anything.
What about TB and sarcoid? Because you placed it only under granulomatous.
Yes, it's usually more granulomatous. In my experience, it's more granulomatous. TB can be chronic. But having said that, you see, sometimes when they come in, they already have the posterior side. Typically in Asia, when we see the chronic, they come in with a syndicate, they have a low grade, and they have a bit of granulomatous, KB, some pigment of varying ages. Okay, but in the whole, they are granulomatous. They don't be fresh like the viral ones. They can be different ages, but they're rounder, the bigger. I favor granulomatous. All right. Then I will start worrying. This is more chronic, and this is more granulomatous, so I will exclude those things. Having said that, there's nothing to say that cannot be an acute manifestation. So again, in those cases, I would treat them. If they respond very well, I won't bother asking them to go for TB medication. All right. So I have some patients on very low that I suspect nothing else is wrong. They only have a MAN2 abnormality, everything else, and they have very chronic uveitis. They need a low-grade steroids, like topical for OM, BD at most, depending on timing. And they do very well, 6/6 vision, nothing. But you can see the posterior semique, all right? And it's stuck there, and then, but everything else, no posterior uveitis, every day is fine. You just drop in that 1 or 2 drops. If they're like that, they're comfortable, I offer them one time, first time, do you want to take TB medicines? They go, no, or do you want to try? I do give them the option. So the thing with TB treatment is that you don't get rid of the uveitis. So after taking the 9 months, it may lessen the immune load and lessen the degree and the number of attacks, but sometimes it doesn't go away because the patient gets this impression, if I take this 9 months, I'll never get a uveitis attack again. Sometimes you have to preempt that you may still get, but it might be not as severe or not as frequent. Of course, if they don't get it, that's great, but if you do see enough, they sometimes still do get. So I do warn them about that. Some patients don't mind if they take it. Some patients don't want to take it, and I leave them as such. Okay, so again, you have to discuss with the patient whether all of them you need to. This is at the end of the day, after excluding everything else, all right, that there's nothing else I can offer to the patient except for that abnormal TB test. All right, and because of the chronicity, well, you want to try treatment. Okay, so for me, I'm not really, I know some people always want to say, this has to have this diagnosis. I'm more concerned is this immune or is this infective? Because I know how I'm going to treat once they have been classified that. Then if I can give them a specific name, I'll be very happy to give them a specific name. I don't rush in to call everything idiopathic because idiopathic means you've excluded everything. And most times we have not excluded everything. So I usually tell them, you just have a very mild uveitis that is responsive to treatment. So and it's not no systemic issues to worry about, so be it. Or you have certain intermediate uveitis that is immune mediated, but not severe again. If it's severe, then I say you have maybe something else. You see, so I don't tend to I don't feel obliged to have to give it a name because I know exactly how I manage. It's slightly different when you want to publish or you want to present, then you want to start, this is pan uveitis, this is whatever. You know what I mean? But as a day-to-day clinician, all you want to know is, am I managing it correctly? Is it active? There's simple questions you ask. You don't really know, is this a pan, you don't need to, you know what I mean? You will know, you know this is a severe posterior uveitis, and you need to look at certain things. So this is this is practical purposes, not for presentation, not for research. Research, you need to go by those definitions and everything like that. But our day-to-day practice is very different. You're not gonna, unless you want to do like research on the sideline, then you stick to them very nicely. But some of us are just clinicians. We just want to treat the patient, get the patient out of the clinic and seeing well, right? Okay, so yeah, I hope that answers your question.
Sorry, I actually have three questions actually. The first thing with regards to the AC tab for your PCRs.
What PCR? Oh yeah, okay.
For the tetraplex PCR. So sometimes the issue is that the minimum volume that you need is 0.2 mils. So
no, it's not. We give 0.1 usually, and it's either. So again, it's whether you trust the results, right? But a positive test is always a positive test. You can believe it. A negative test is nothing. Okay, but it gives you a little bit leeway to show. It either means the load is so low that it's not detectable, right? Or it was out and it's gone back into latency already. It's not an active viral infection, all right? So that's number one. And then, so I never really take a negative as a pure, but it gives me a guide. So if I need to start, if there's a lot of inflammation, and you're asking this because of maybe a CMV I use,
yeah,
because typically they sometimes have the inflammation, and so for CMV ones, if they don't need the steroid, I don't give it, because you actually gauge by the amount of inflammation. And typically, actually, you'll find that a lot of them that are negative may not have, so they are maybe like the Portner-Schlossman type, where there's not much inflammation, and then they don't really need it. And sometimes by the time they see me, right, everything is already under control with just acula and SIDS only, and the inflammation is quite quiet. I don't beg the question and give the steroids, you see. But if they do need it, we can give a little bit of low dose, but be mindful, don't like keep it forever. Stop it as soon as the inflammation, so watch them very closely and then stop it as the minute the inflammation goes away, right?
Is there a difference in accuracy between a tetraplex PCR versus a monoplex with the test?
Yeah, so yes, we have had cases where the tetraplex is negative, but you do a real-time PCR and it's detected. So again, is how clinically suspicious you are. So if you look at it and say, this guy's not responding to therapy, this guy's getting worse, and I would chase and I would tap them repeatedly, or I may even just treat appropriately with just the topical. You can't give the systemic, but you can give the topical, right? But again, I would take the whole picture. Is the patient getting worse? Is it just a few cells that's there, but vision is very good, there's no glaucoma, there's no endophthalmitis? Then should I be so aggressive to just treat the cells if the patient's asymptomatic? So again, so I can't answer that question because I don't know, because sometimes we get surprised. Sometimes it's negative and then we ask for CMV. Sometimes, you never know, right? So again, how aggressive I am at it is, or how much I would ask for both is how suspicious when I see the patient. If I look at it, I really think this is a CMV, everything, the endothelial cell counts are down, there's difference, the kidneys look typical ring shape, or, everything seems to be matching, the stroma atrophy, hypertensive uveitis, all the tick questions are there, then yes, I would maybe set for both just to be safe, all right? So that's uveitis. You can't, so people always say, I want that answer, magical number of how many times to do this, there's no magical answer. It's just based on clinical experience. So I want to reassure you, don't feel bad if you don't have that number and you don't have that magical question and you don't have that. But if the first one is negative and they do very well, I don't chase, right?
Can I ask about the TB PCRs that you were showing us now? So in the context of cases where you suspect ocular TB, do you do TB PCRs, aqueous, vitreous, or do you rely on
I do, but they've always been negative. We feel that in our setting, we don't have the right primers. You should speak to Dr. Vaishali and Dr. Amakota is here. In India, they have multiple primers. Unfortunately, we only have limited primers. So it's either we're not detecting. In SGH, we recently changed the primers, so see if we increase our detection rate. But I do it because if we poke the eye and there's sufficient fluid, it's so precious, if it comes out as a positive, most of the time I'm expecting a negative, but if it comes out positive, that will really help me clinch the diagnosis. And you never know the day. And if I have, so it will be on my last of everything I need to rule out, I'll put it on the last, because if it's negative, I'm not so, but if it's, I never know if it might turn out positive one day, and I don't want to be caught out, I will send it, because it's so precious to poke the eye. I'm not going to poke the eye again, you know. And most times patients, one time, it's like, that's it. Because I mean, very few patients let you do it many times. So I don't. But having said that, locally, you have to look at the patient. Locally, I feel that most of our TB are immune-mediated. All right. So I don't really think that we will ever, unless they have been or they come from India, then it's a different story. Okay, because the disease is different. Or if they come from another place, if they're local Singaporeans that tend to, if they're foreigners, I may take it differently because the disease is different from each region. So as we say this, take it with a pinch of salt. This is Singapore predominant, but we have a little bit of experience with the region. But again, it really matters what you are seeing in your regional area.
And last question, with regards to scleritis itself, from the investigations, I mean, there's an overlap between idiopathic orbital inflammatory syndrome, possible scleritis. So, would you do a CT orbits for some?
Only if there's swelling, right? If there's soft tissue swelling. So I have recently a case like this. So it comes in with scleritis, even nodular. I worked out okay, autoimmune, and happens to have some autoimmune, ANA, speckled, okay, so fine, scleritis. And then, when I taper the steroids, he gets better with the steroids, so fine. Then I taper the steroids, then he starts getting inflammation that's worse. Eyelid becomes swollen. And of course, I'm on steroids, I'm thinking, oh my gosh, does he have, so he's also diabetic. So do you think, oh my gosh, could it be that I'm giving him orbital cellulitis for some reason or other, because he's diabetic and he's on high dose oral pred for like 2 weeks already, you know, something like that. Then, so I said, okay, do a CT scan, because that's useful, right? CT scan comes in, no periosteal, like cellulitis kind of picture, but lacrimal gland swelling. So then that's when you do it, because you want to have a sign, but you don't do it preemptively if everything else is fine, right? Because you can see if there's swelling, right? But then the thing is, you must look, right? Because a lot of us out there's no swelling, but did we really look? Did you really lift up the lid? Did you really look at the eyelid and compare everything? So you must really look. So that's the difference. So you do need to do it occasionally. And you always need to be mindful that scleritis can be posterior and can affect the soft tissue and of course the nerve as well. So uveitis is really a very difficult field that we need to know. So most of us are specialized so that we can focus on one field. Uveitis, we start specialized to specialize in almost every other field, right? So, but it's fun because you know, you can work out and there's like it's like being a little detective, and then you actually do this and you actually learn so much more about the eye, right?
Do you routinely do a B scan to look up for the T sign in the patient?
Yes, I do. It's a simple test. Not every single patient.
Yeah, okay, I asked this because there was once when I was junior many years ago, there was this patient with anterior scleritis and he had not much pain, well, a little bit of pain, but there was no disc swelling, the macula was fine, everything was fine, and then the reg and call decided to do a B scan and they saw a T sign. So.
Well, again, sometimes you don't know until you do things. So if you hadn't done it at that setting and the patient got worse, and if he really had a T sign, he would have invariably got worse, you would have picked it up sooner or later. This vision would have dropped. It's just that you picked it up later. So yes, you can do it for every patient, but the pickup rate may not be high, all right? But if you do, and if they progress, you will pick it up, right? That's my point, is you can do everything. And first day you can do everything, but you know, it's for every single patient, it's a little bit hard sometimes. But if you see, if the pain is out of proportion, the vision loss is not equivalent, something is not right, then do. No harm, simple test, not invasive. Doesn't take any more of your time, right? No harm. But if you're really busy and everything looks fine, vision is great, nothing much, then, and you're going to follow the patient, right? You're not going to discharge and say, oh, scleritis here, don't come back, you know. You're going to see him in 1 week's time, right? And 1 week's time is not better, you can still do the B scan and you'll still detect it, right? So even if you don't do it first time, you will be able to detect it. I'm not saying that you won't, but you can at least have good evidence to do it. You get what I'm saying? Yeah, but sometimes you do it for fun, and sometimes sometimes residents do something, oh, you detect something that you may not detect. And sometimes it's just fortuitous, something you do it. Sometimes you don't, because it's just too busy and you just can't do it for every single patient that walks in, right? Then you wait for something that gives you an idea that it's not doing and do it. So anyways, I think it's time for your tea break, so... Oh yeah, sorry.
Actually, it's between culture versus PCR. Like, what are the situations where you will advise both culture and PCR, or where only culture or only PCR is?
I do say, infective. So if there's a hypopian, I'm more worried about bacterial, not do cultures only. But there's only one when it's post-op inflammation. Okay, post-op inflammation with which you're not sure. Is it? When I say culture, I'm not worried about bad bacteria. I'm worried about P. acnes. Because chronic inflammation, they can give fine PPs, chronic inflammation kind of thing. And then are you worried about CMV, tetraplex? Those I would do both. You know what I mean? When it's
any case of undiagnosed case, but we suspect a kind of infective etiology, but we don't know exactly what is the etiology. So
yeah,
you have access to both PCR and.
Yes, I would do if it's a very bad case and I need to know the answer and I'm not going to poke the guy. Well, no harm said. If you have enough specimens, I'll send both. But typically, so you know if there's a hypopian and it looks like a bacterial, I won't do a tetraplex. And the retinite is a choroidal abscess or something like that. You won't do a tetraplex. But if it's a funny lesion and you're not sure, it could be a choroidal, could be something else, could be toxo, because toxo sometimes looks different. So my tetraplex has toxo, it's vis-a-vis HSV, CNV and toxo. Then yeah, you can throw in the tetraplex in. Alright, so, but I don't do it just, hypopian, do both. No, you have to look at the factors. The only one I do both is for those like, it could be a P. acnes, it could be a CMV, and I want to answer both questions. Yeah.
So my second question is, you told about the vitreous samples, diluted and undilated samples. So suppose vitrectomy started, still you can send the sample? Or
I accept, because I work in the pathology, and the pathologist was like, what's this bag? What am I supposed to do with it? I just ask them to pass the bag, because sometimes that's the whole vitreous, so sometimes it's useful. The only thing is, if you're doing a phaco at the same time, then it's a bit problematic. You want to do, you need to exchange bags because you don't want, or you have to tell the pathologist to spin down and get rid of the lens. So sometimes, if there's a phaco, then I tend to ask them maybe, that is slightly different. But if there's no phaco involved, it's just a diagnostic, then yeah, send both, if possible.
You need a more amount sample in that?
Yes, I do. Sometimes, depending, so sometimes, the vitreous has compartments as well. The anterior vitreous sometimes is more reactive, and the deep vitreous is sometimes more diseased. And we've seen this because we've done like a sequel, we have a bedside vitreous tab, and then it shows nothing but inflammatory cells. Then we do a vitrectomy, and then the deep cells show, wow, it's all cancer cells. So we do see a gradation of inflammation based on that. And so I do advocate sending, if I can't see the need, I will get the whole vitreous and look at it. Yeah.
And like in case of retinal biopsy, a couple of times our pathologists, they rejected the sample, like it's very small.
Yeah.
So any particular, like anything?
No, you need to, that's why you need to, that's why we have ocular pathologists, because we are not afraid to handle, but you need to educate your pathologists and tell them it can be done. Because a lot of them is not, is always an issue for a general pathology lab, but if you can educate them, or you can send them to like say a center that has somebody with some eye pathology, they can handle it. It is very small, but we've been able to, so I usually tell them to orientate it onto a filter paper so it's flat, so you can spread it out as much, because if you give them to handle, they'll just be one ball of like tissue. But if you put it on the filter paper, after you do put it on the filter paper. If not, if you have a cytologist, send it as cytology. They will know how to handle it. So the pathologist has a cytology arm. The cytology person is different from the pathologist. The cytology tends to handle smaller specimens. So if you really piecemeal it, so I've had cases where they do it, they can't peel it off, they use the vitrectomy cutter, cut it in piecemeal, send it as a cytology. And then they can still do the. And in India, they're very good with this. You can ask Dr. Vishalya how her team does it. But for us, we can, so sometimes they just send it as a cytology, and that, they can spin it down. So the cytologist may be a better person to handle those cases. So you can speak to them and tell them, look, I'm going to send you this, and ask them how to manage it.
Thank you.
we know that retinal vasculitis, one of the complications is occlusive vasculitis. Is it all the vasculitis causing the occlusive vasculitis or certain condition that more prone to get this?
Yes, there are more certain conditions more prone, but again, there's no hard and fast rule, so you always have to monitor and follow up. I mean, just because we treat the uveitis, we still have to look whether there are new vascular formation, there's edema, complications, all that kind of stuff. So a lot of times I find that my CNVs, they're very occlusive. Batches sometimes. Sometimes it's just a phlebitis. So if the degree becomes like a CRVO picture, then you have a CRVO, you know. So you still, so there's no hard, so CMP, definitely. You just see the degree and whether they have ischemia, and then you look, oh, there's so much ischemia, I think this guy is going to, preemptively you can do the laser. Right? Ask him to go for laser. You do FFA, you find out, oh, I think not so good. So again, sorry, no hard and fast answers, but again, always look at it and see. So yes, I do, not specifically. So anybody who has vasculitis and a lot of hemorrhages, I would monitor them very closely for the complications of that occlusive event, whether it just resolves and it perfuses again. Sometimes they perfuse and everything is good, it settles 6/6 VA, right? But still, you see that they're starting to get ischemic changes, right? Then I would just send them for, because your steroid will deal with the CMO and everything, so you will not see that and everything like that, right? But then you still see the neovascularization going on. Then you would want to send them for laser earlier on, preemptively. So we have overlap with medical rep as well. So if you ask, what field should you train in? I really don't know, because you need to know medical rep, you need to know glaucoma, you need to know cornea. Yeah, so it keeps you on your toes.